Ladies and gents, today we're going to be talking about angiography. We're going to be focusing on the techniques that are employed under the name of angiography. There are different approaches. We're going to be covering those, and we will also be giving you some idea about what are the pros and cons associated with each technique. We'll also talk about the brief history of the angiography technique, and then we'll wrap up. So let's begin. The definition. I wanted to give you a very basic definition so that you would have a simple idea about what this is. It is basically a medical imaging technique used to visualize the blood vessels and the organs with particular interest in the arteries, veins, and the heart chamber. This technique is important because we, during our daily lives, we come across with a lot of pathologies related to the blood vessels, vascular pathologies I'm talking about. And this can be strokes in people's brains. This can be problems related to the coronary arteries of a person, which is never nice, and therefore this technique carries a high importance in the vascular pathologies, their detection, the interventions that are done to prevent harm to the patients. So, as always, we wanted to give you an idea about what the history of this was and the development that occurred. In Portuguese, in 1927, in Lisbon, a doctor named Egas Moniz was the first to describe the use of angiography, and it revolutionized the field, and it continued to be very important until 1975, and that was when the computer tomography was introduced. Until then, what he did carried the importance that was grand. So on the right, you see the pictures that he put on the paper that he published in French. At the top, you see you're looking at the head of a dead body which was fixed in formalin, and he used sodium iodide to visualize the carotid artery and its branches. In the second picture from top, you're looking at a dog's head. It was an alive dog whom he undertook angiography procedure, and you see the vessels, and at the bottom, the picture C, you're looking at a living person, and this person actually had a pituitary tumor, and he had Babinski-Furley syndrome, some developmental issues, and etc. So he was able to do the procedure without causing trouble to the patient. So there are three different types of angiography. The first one is conventional angiography, which remained the gold standard for a long time, and for some doctors it still is the gold standard. The second technique is magnetic resonance angiography, and the third technique is the computed tomography angiography. Here there are different pictures of the angiography procedures using different approaches. At the left, you see digital subtraction angiography. You may wonder why the conventional angiography is now named digital subtraction angiography. We're going to be covering that. We're going to be covering what digital subtraction means and also what the conventional is actually. So, yes.
My name is Nilüfer Manzadeh and I would like to talk to you about the digital subtraction and geography. So DSA is a computer-assisted process which enables visualization of arterial structures after intravenous injection of contrast material. The general procedure involves inserting a catheter, which is a small thin tube, into an artery in the leg or groin and passing it up to the area of interest. After that, the contrast agent is being injected into the artery of interest and a series of radiographic images are being taken. The contrast agent increases the contrast of blood vessels on the radiographic image. And finally, the digital subtraction, which will be described later, is performed with the help of a computer. Now I would like to talk to you about the Seldinger technique. Seldinger technique played a huge and crucial role in the development of angiography. It enabled radiologists to obtain safe access to blood vessels via catheterization in the least invasive and most risk-free manner. In order to perform this procedure, we need first to puncture the vessel of interest with the help of a needle, and then we must to insert a guide wire through this needle and advance it into the lumen of the blood vessels under the guidance provided by fluoroscopy or ultrasound imaging. Then the insertion site is being enlarged with the help of a dilator because the catheter which is going to be inserted afterwards is larger in diameter than the guide wire. Then the needle is removed and the catheter is inserted and advanced until the guide wire comes out of catheter's other end. Finally, the guide wire is gently pulled out and the internal placement of the catheter is confirmed by fluoroscopy. After we insert a catheter, we must inject a radiocontrast agent. But let's first clarify what is radiocontrast agents. So, radiocontrast agents are substances which are used to enhance the contrast of internal structures in X-ray-based imaging techniques, such as computer tomography, projectional radiography, and fluoroscopy. In angiography, iodine-based contrast agents are widely used. That's because iodine has innermost electron binding energy of 33.2 keV and is similar to the average energy of X-rays used in diagnostic radiography. And at this particular energy of X-rays, iodine atoms absorb more X-rays via the photoelectric absorption. Now I would like to talk to you about the general principle of DSA. As the name implies, DSA is performed by digitally subtracting two images. First image is the non-contrast image or the mask image, and this image is taken before we inject the contrast material, and it only shows the anatomy of the region as any X-ray image does. So you can see from this image, this is the pre-contrast fluoroscopic image taken before the injection of contrast agent. Then, while the contrast material is being injected, a series of images are being taken as the contrast agent travels down the blood vessels of interest. After that, the actual subtraction process takes place, and this is done by subtracting the mask image from the series of post-contrast images pixel by pixel, and the resulting subtraction images show the field vessels only. These images now show better illustrate this concept. So again, here you can see the mask image per contrast image is constant for all images, and the post-contrast images are taken successively as the contrast agent travels down the vessel of interest, and the digital subtraction image looks like this. It's another image, and this is like a post-contrast image. taken after the injection of contrast agent, and this is a number of digital subtraction images taken while the contrast agent travels down the blood vessels of interest. DSA imaging systems are generally based on integrating fluoroscopy systems with computer technology and are made up of X-ray generator, a field restriction device or collimator, filters and anti-scatter grids, an image intensifier, a video camera, image processing computer, and display monitor. Our classmates already talked about the fluoroscopy on lesson before, on presentation before, so I will just go briefly over the fluoroscopic components and over the concept of fluoroscopy. So fluoroscopy is an X-ray imaging modality in which the images produced appear in real time, and this allows evaluation of dynamic biological processes. Electronic fluoroscopy creates this perception of this X-ray video by capturing and displaying images at a high frame rate, typically 25 or 30 frame rates per second. At this frame rate, the human visual system cannot distinguish frame-to-frame variation, and motion appears to be continuous. So the X-ray generators are quite similar to those used in radiography, as well discussed in medical imaging lessons. However, there is an added circuitry for fluoroscopic operations, and they include automatic brightness control, which allows to keep the overall brightness of the image seen on the monitor at a constant level, and this is done by automatically adjusting KVP and current values. Another circuitry is involved for the rapid pulsed exposure, and this means that the exposure is delivered in short pulses, 3 to 7 millisecond in length. This increases temporal resolution, allowing examination of rapidly moving structures in cardiovascular applications. And since the radiation is being delivered in pulses, the overall radiation dose is also decreased. So this picture illustrates the X-ray generator with control panel. Then, after being generated in X-ray tube and generator and being controlled by the panel, X-rays pass through the collimators and anti-scatter grids. Collimators confine the X-ray beam to an area of interest defined by the user. In fluoroscopy, the collimation can be rectangular or circular in shape, and it matches usually the geometry of the image intensifier. As remember, the X-rays can interact with the body in 3 different ways. They can either be transmitted, absorbed, or scattered. Scattered is the least desirable effect, so because it produces just unnecessary noise in the image, and we want to get rid of this scatter. For this reason, we use anti-scatter grids, and they improve the image contrast by reducing the scattered X-rays. For a large percentage of fluoroscopic examinations, which are performed in high scatter conditions, these components are quite crucial. After that, after passing through the patient and being exponentially attenuated, the X-rays, they pass through the image receptor and X-ray intensifier. X-ray intensifiers are capable of increasing the intensity of the output image by 10,000 times than the input image. When the X-ray exit radiation strikes the input phosphor, it gets converted into visible light. Then light intensities, which are equal to the intensities of the exit radiation, are converted to electrons by a photocathode. Photocathode serves this electron emission purpose and emits a lot of electrons to the space. Those electrons are stirred, accelerated, and multiplied in number by the electron optic components, and finally they get converted to visible light photons by output phosphor. Now you may wonder how it manages to increase the brightness by such a large factor. Well, the thing is, accelerating the electrons increases the light intensity at the output phosphor, and this is called the flux gain. Also, you can see that the output phosphor is much smaller in size than the input phosphor, and the reduction in size also increases the light intensities, and this is called the minification gain. So the overall brightness gain is a multiplication of the flux gain and the minification gain. After the image leaves the intensifier, it gets converted to electrical image by a video camera, and then it enters the image processing unit. Image processing unit is the heart of DSA. This is where the actual subtraction takes place. The video signal then passes to analog to digital converter where the image is being converted from analog to digital format. Then it enters the iLoot component, which is input lookup table, in order to be logarithmically amplified. So why do we need to logarithmically transform those images? Recall that the image is formed by detection of X-rays that have been attenuated exponentially in the body. And if logarithmic subtraction is not done, the brightness of the object in the subtracted angiographic image, such as vessels with contrast materials, will vary according to the brightness of the underlying tissue in the non-subtracted images. Then the amplified image enters the image memories. So there are at least 3 image memories required for routine DSA. One for each of the mask and leave images, and the third for the subtracted image. After that, the image subtraction is performed in ALU or arithmetic logic unit, and the subtracted image is being fed back to the image memory where it's being stored. Then the resultant image after the arithmetic processing is reconverted by a digital to analog converter into a composite video, and is either displayed via the video monitor or is being stored on the disk storage. So there are some important image processing steps which are being performed in image processing unit, and actually they are being done in this array with the help of this array processor. And I would like to talk to you in more detail about those steps. First is the pixel shifting. So when we are performing DSA, we assume that the mask image and the successive images taken is like the body does not move at all when we are taking those images, because we want them to coincide in order to the top subtraction to be quite precise. However, it's not the case, and the patient body can move through the imaging process, and these imaging artifacts look something like this. And pixel shifting is a process performed to reduce motion artifacts. This involves spatially shifting the mask image in small increments relative to the leave image in order to reduce this misalignment between mask and successive images. The second image processing step is called spatial enhancement. The thing is, when we are subtracting images, the signal to noise ratio decreases substantially, and this spatial enhancement is performed in order to highlight the vessel structure of the subtracted images, so that the edges of the blood vessels are displayed with increased prominence. You can see from this image how it is being performed and its effect.
Continue with the magnetic resonance angiography. So this is basically a group of techniques employed using the magnetic resonance imaging only for imaging the blood vessels. It's commonly used for evaluating arteries for stenosis, which means abnormal narrowing in the blood vessels that would cause problems, and other things such as occlusions, aneurysms, and other abnormalities. So why would someone use the MRA specifically instead of the other techniques? With MRA, what we have is that it demonstrates vascular information in 3 dimensions. It provides us with the information regarding the velocity and volume flow rate of the blood. It can also produce angiograms without the use of an iodinated contrast material or ionizing radiation, which might be a problem in your case. And lastly, it permits the imaging of soft tissues, providing the ability to see both vascular pathology and its effect on the target tissues in a single exam, which is a lot. So there's a picture here, someone going through the MRA procedure. So yes, what do the doctors want to do with this technique? They want to find aneurysms, which are problems related to the blood vessels inside your brain or somewhere else, but it can cause serious damage to a lot of different functions, daily functions you have in a day, and therefore it's very important to find it and intervene. Um, the doctors might also look for the causes of a stroke. If they were looking at your heart, they might look for signs of heart diseases, which we mentioned before. They might look at the coronary arteries. And magnetic resonance angiography has a lot of different approaches in it itself, and some use the contrast material, some don't use the contrast material, but if they do, they're going to have a dye going through to their bodies using an IV. So since we have this medical imaging courses and we're engineers, we're not going to be looking much into the medical side of things, but rather more focused on the engineering side of things. And therefore, we're going to be examining 3 different phenomena that exists with the MRA techniques, and we're going to be mentioning about what they are, how do they occur, and what do the engineers do to fix those issues, to provide a higher quality imaging, better serving imaging. So let's continue. So 3 different phenomena. These are intravoxel dephasing. The second one is signal saturation, and the third one is signal ghosting. Let's examine one by one. So with intravoxel dephasing, I'm gonna tell you a bit about the MR, which we already been learning some imaging in the past, but it's still good to talk a bit about it. With the MRI, the largest signal that is produced is when the transverse components of the magnetization from all of the nuclei within a voxel are aligned with one another. Now, a voxel means basically a pixel, but only in 3 dimensions. So we receive so it's very important that we have alignment. That's the largest signal we get. A large net signal occurs when they're aligned and rotating in synchronization, enabling constructive adding of all signals from the magnetization. And so it's very important that they're aligned and rotating in synchronization. But intravoxel dephasing occurs when the nuclei in the same voxel start to rotate at different rates. So there's a picture here. It was taken from a textbook, and as you can see, intravoxel dephasing occurs this way. You see there's the blood vessel, it's kind of like shaded. We don't really see what's happening there, but these sorts of things, intravoxel dephasing causes signal loss in regions of magnetic field inhomogeneity and at interfaces of tissues having different magnetic susceptibilities. And this means that if there's a change, if there's an interface of change, you're going to have issues with the MRI and MRA in this case. And due to several different pathologies, complex patterns of blood flow can be created. So this means that, let's say we have different flows, it's not really a stable environment, uh, especially in the case of a narrowed vessel. This sort of thing can happen. And in that case, things like stenoses, complete loss of signal can occur. And as you can see from the picture, we don't see that part of the vessel, and uh, that could tell the doctor that there's a problem. But for obvious reasons, because we're not really seeing what's going on there, the doctor can't say what sort of pathology this is. So there are a number of techniques that are used to reduce the intravoxel dephasing. One of them is the shortening the echo time. Basically, this is a technique that reduces the amount of time that the magnetization is permitted to phase. So you're basically being very quick about your uh, echo times, and this is basically the time that you get the signal back. To reduce the occurrence of the intravoxel dephasing. One of them is the shortening of the TE, which is the echo time. It is designated as the time between the application of the radio frequency excitation pulse and the peak of the signal induced in the coil. So if you reduce it, if you employ shorter TEs, the intravoxel dephasing will decrease as well. Another option is to use smaller voxels. The amount of magnetization that is permitted to combine coherently is reduced, thus limiting the signal loss. So you're basically reducing the size of your voxel, and therefore you have much smaller combinations of nuclei, for example. And therefore the rogue ones, the ones that are not aligned, the ones that are not rotating in an aligned manner, are reduced. Also, another strategy is called flow compensation. This is basically an enhancing feature that is adopted, and we will be going into more detail about it in the next slide. It eliminates the phase shifts accumulated by blood that is moving at constant velocities. So basically, when we have the MRI, we look at the blood flow, and the blood flow can be problematic since it's not really stable. And as you know, the MRI machines, they don't really like the movement. There was a strategy that was developed. So what is flow compensation? It is an imaging feature that eliminates the phase shifts accumulated by blood that is moving at constant velocities, and it can also be referred to as gradient moment nulling. So about this other name, and this technique it was developed in the 80s, and several companies have followed similar strategies but named them differently. So the big companies like Siemens or some of the other Japanese companies each have their different name, each have their own name for the same concept. And the most popular one, from what I saw, is the gradient moment nulling. But just in the book that we used, it mentioned this as the flow compensation. We're going to be using that name. Let's see. This sort of compensation, it makes some assumptions. And it compensates, obviously, from the name that you can understand from the name. So if there's a consistent flow, we can do something about it. We can do something to prevent our images from being weird, um, and reduce the intravoxel dephasing. So how does the flow compensation work? Very easy question I wrote, but that was actually sarcasm intended. Um, it's not a really easy concept, but let's see it this way. Uh, with our MRI machine, what we want is we want alignment. We don't want rogue directions of rotation, or we want things to be orderly. That's what the magnetic field does. With the intravoxel dephasing, we have we have nuclei that's kind of rotating in different places. And what the flow compensation does is that it basically creates gradients. As you can see, there's like a +1, and there's like -2, and there's also again a +1. What happens is, so firstly a positive gradient is created, and then you change the direction. You get the double, uh, you get a squared power of this in the other direction. You have a negative gradient, and then you will change it again back to the +1. What this does is, you can see it this way, it basically gives the rotation a good manner. It basically kind of makes it changes back and forth, and in the process we have a much stable, stationary, well, we have a better image. That's how it works. The second phenomena that occurs that prevents us from having good images is signal saturation. Uh, Diminution of signal caused by rapid and repeated application of radio frequency excitation pulses to an image slice or volume. The rapid and repeated application of these pulses limits the regrowth of longitudinal magnetization of blood. This reduces the magnetization available to generate signal after application of subsequent radio frequency excitation pulses. So basically what happens is, and this is the case with MRA, you constantly bombarding the material with your pulses. And if you don't let it relax a bit, you're not going to get a good image, because the difference between the relaxed version and the excited version of these hydrogen atoms we have is it is what gives us the picture. If you don't let some sort of a relaxation, you're not going to get a good image, and that's why it's called signal saturation, because it is saturated and you can't saturate it further or anything, and therefore you're not going to get a difference, and therefore you're not going to have a good image. All MRA methods employ rapid application of radio frequency pulses. We have like short repetition time. Therefore, it is an inherent limitation. You're going to have it with all of the techniques. The more radio frequency pulses blood experiences, the greater the saturation, until eventually an equilibrium is in reach. So I wanted to, these concepts are very abstract, and I know that we really are diving into these imaging techniques this year, but I wanted to give you a good idea about what these things are, how do they prevent, how do they cause problems with our imaging, and therefore I put some images. I put it with the intravoxel dephasing, and this is also a good image for the signal saturation. As you can see with the arrows, it becomes sort of blurry here. You don't really see the whole picture. It gets shaded like in the previous picture, and here you have two images. One of them is more prone to saturation. This technique is a different one. This is a contrast enhanced MRA method. and Yusuf will be talking about that more. But this is the difference that occurs. This is without the saturation, this is with the saturation. As you can see, it's a real problem. So there are different signal strategies to reduce the signal saturation. Increasing the TR, basically this is basically the repetition time. How much time passes between your pulses. Uh, if you increase it, you're going to give it more time to relax. Reducing the tip angle, well, you might be wondering what tip angle is. There's a very abstract definition again, sorry, but it is the amount of rotation the net magnetization experiences during the application of an RF pulse. Um, I really don't want to get into much detail about it. I just wanted to familiarize you with the concept. Uh, as another strategy, decreasing the thickness of the image slice or volume. Um, you can, if you decrease the thickness, you're going to be having many more layers to go through, but it might help. Strategically prescribing the acquisition to ensure the blood spends little time in the slice. So yes, this is also nice because blood is the thing that's causing the problem, sort of. Administering a T1 shortening contrast material. Again, this is, as we mentioned before, with some of the techniques labeled under the MRA, you have the use of contrast materials. They help, but there are pros and cons with the use of them. So the third concept that I wanted to familiarize you with is the signal ghosting. It is a funny name actually, but this one is a very simple concept. So basically what happens is we have replication of the signal in an image. We have something that we want to look at, but that somehow gets replicated and appears on different locations in the image. Since they're not actually there, we call them the ghost, hence the name signal ghosting. Here I have a very good image of that. You can see this is the real deal we want to see, and here you see these ghosts. So variation of signal intensity throughout image acquisition is a common reason for signal ghosting. It can happen due to the rhythmic beating of the heart. This is, again, I mentioned before, the blood is really the tricky part here. It can be avoided by collecting data always at the same time frame or phase within the cardiac cell cycle. So you want to understand, you want to avoid the changes. You want to make sure that you get the image at the exact time interval before, hence you won't see the variations. So now Yusuf will take over and give you some basic idea about the three different types that are inside the MRA. I know that it's been kind of intensive because you learned about the different techniques of angiography first, and now you hear that there are actually different techniques under the MRA. But believe me, it's something interesting, and
Now I'm gonna be talking about some types of MR angiography. Let's start with definition of phase contrast MRA. Phase contrast angiography relies on dephasing the moving spins submitted to a bipolar gradient. For a bipolar gradient of a given intensity and time, the moving spins will dephase in proportion to their velocity. Phase contrast MRA is similar to conventional X-ray angiography in that both methods employ subtraction to eliminate signals from stationary tissues. As a result, only signals from flowing blood are present in the angiogram. Phase contrast MRA differs from conventional X-ray angiography in that no contrast media injection is required with the former method. The mechanism responsible for generating signal in phase contrast MRA is the motion of the blood. Phase contrast techniques derive contrast between flowing blood and stationary tissues by manipulating the phase of magnetization, such that the phase of magnetization is zero for stationary tissues and non-zero for moving tissues. The data acquired with phase contrast technique can be processed to produce magnitude, phase difference, and complex difference image. In magnitude image, the strength of the magnetization at each point in the objective is displayed in approximate pixel in the image. This is the typical display method employed in general MR imaging. With phase contrast method, the phase of magnetization is manipulated, but strength of magnetization or its magnitude is unaltered. Thus, displaying the magnitude of the magnetization permits simultaneously demonstration of vessels and stationary tissues. In phase difference image, the signal is linearly proportional to the velocity of the blood moving. In a one direction is assigned a bright signal, whereas blood moving in the opposite direction is assigned a dark signal. This characteristic of phase difference image permits arteries to be effectively differentiated from veins when they are aligned antiparallel to each other. Phase difference image also can be used to detect retrograde flow. In addition, it can be used to determine quantitative information regarding speed and direction of blood flow. The signal in each pixel in the phase difference image is linearly proportional to the velocity of the blood or tissue represented by that pixel. So a cursor or region of interest can be placed on the image and a direct measure of the velocity of the blood or tissue can be determined. If the cross-section of a vessel is demonstrated in the image, information regarding the volume flow rate of the blood in that vessel can be derived and it can be calculated from the equation. These photos you see are magnitude image and phase contrast image. The rightmost photo was obtained by combining other image. In complex difference image, the signal strength is dependent on velocity of the blood. Furthermore, the direction of blood flow is not represented, so flow in opposite direction is not represented as bright and dark as it is in phase difference image. Therefore, complex difference image are not used to determine quantitative information regarding blood velocity or volume flow rate, but are used for demonstrating the anatomy of the vessel. This is another term we will learn about MRA. Let's talk briefly about that. Phase contrast methods are sensitive to a range of velocity. To specify this range of velocity, the users choose a velocity encoding value. This range designs the flow velocity to be encompassed within the maximum 360 degrees of phase shift. The velocity encoding is inversely related to the area of the flow encoding gradient. Hence, for the imaging time to remain unchanged, stronger gradient amplitudes are required to encode smaller velocity. The velocity encoding is given in centimeters per second. It determines the highest and lowest detectable velocity encoded by a phase contrast sequence. Blood traveling at velocities higher than the encoding value will be misrepresented in the image, so the user must choose this value carefully. This misrepresentation is referred to as velocity aliasing and appears differently in phase difference and complex difference image. In phase difference image, a last signal is easy to identify by an abrupt decreasing signal for blood traveling at increasing velocities above the velocity encoding value. Blood traveling at some velocities above the velocity encoding value gives rise to no signal at all. Thus, with easy to identify, with both phase difference and complex difference processing, choosing a velocity encoding value that is too low or too high should be avoided, because it leads to all blood magnetization accumulating only small phase shifts, which result in low SNR and small signal range. You see an example here. Phase contrast methods are implemented using two-dimensional or three-dimensional acquisitions. Two-dimensional acquisitions can be completed rapidly and are effective for localizing vessels that can be more thoroughly evaluated using other MRA techniques. In this manner, the 2D PC serves as a vascular Scott series. It is also effective for performing cardiac gated scans as described previously. Three-dimensional acquisitions are more time-consuming than two-dimensional acquisition, and thus are used less frequently. Due to the long scan times associated with 3D acquisition, they are not commonly cardiac gated. Benefits of 3D acquisition include an inherently high signal-to-noise ratio and small voxels. High signal-to-noise ratio due to the effective averaging of signal that is acquired throughout the entire scan. Small voxels due to the encoding methods employed. Time-of-flight MRI techniques differ from phase-conscious techniques in that the former do not employ subtraction, so some signals from stationary tissues remains in the angiogram. In addition, time-of-flight techniques do not provide quantitative information regarding velocity or volume flow rate. Thus, these methods are used primarily for assessing vascular anatomy. Time-of-flight techniques derive contrast between flowing blood and stationary tissues by manipulating the magnitude of the magnetization such that it is large for moving blood and small for stationary tissues. This leads to a large signal from moving blood and a diminished signal from stationary tissues. In time-of-flight imaging, the goal is to subject the flowing blood to at most very few excitation pulses and to subject stationary tissues to a large number of excitation pulses, thereby achieving a signal difference between blood and stationary tissues. This can be accomplished by imaging silos or thin slabs oriented perpendicular to the primary direction of flow. When this is done, the moving blood enters the slice fully magnetized, experiences only a few excitation pulses, and then flows out of the slice before it becomes saturated. This can be accomplished by imaging silence or thin slabs oriented perpendicular to primary direction of flow. When this is done, the moving blood enters the slice fully magnetized, experiences only a few excitation pulses, and then flows out of silice before it becomes saturated. This ensures that the signal from blood will be relatively large. The stationary tissues, however, remains in the slice or slabs throughout image acquisition, so they give rise to diminished signal because the magnetization from them is saturated. Time-of-flight methods can be implemented using 2D or 3D acquisition. In 2D acquisition, time-of-flight imaging uses a set of fine slices that are stacked up to reconstruct a pseudo volume. The advantage of fine slice is better sensitive to slow flow, which do not remain in the slice for long and will therefore not be saturated. But the drawback with 2D acquisition is poor spatial resolution along the axis of the slice stack. 3D top volumetric imaging gives good spatial resolution in the three spatial directions with a better signal-to-noise ratio. Each repetition exacts the volume, producing a progressive saturation of the flow, even more so when they are slow. The slowest flow may even disappear entirely. Contrast-enhanced MRA techniques are most recently developed MRA method. They are probably the easiest to understand of the three classes of MRA techniques, and when implemented properly, they provide diagnostic quality image under very diverse conditions. Contrast-enhanced MRA techniques achieve signal difference between blood and stationary tissues by manipulating the magnitude of the magnetization, such that magnitude of magnetization from moving blood is larger than the magnitude of magnetization from stationary tissues. Manipulating the magnetization to produce signal difference in contrast-enhanced MRA techniques is achieved not only by employing the appropriate sequence parameters, but also by injection of contrast material intravenously. During the first phase of contrast material, image can be acquired that show arteries with striking contrast relative to surrounding stationary tissues and veins. Contrast-enhanced methods have been used successfully to image vessels throughout the body, including the carotid and vertebral arteries, the aortic arc and great vessels, the renal and abdominal arteries, and the arteries of the upper and lower extremities. MRI contrast agents are used to improve the visibility of internal body structure in magnetic resonance imaging. The most commonly used compounds for contrast enhancement are gadolinium-based. In MRI scanner, sections of the body are exposed to a very strong magnetic field, causing primarily the hydrogen nuclei of water in tissues to be polarized in direction of the magnetic field. Gadolinium-containing MRI contrast agents are the most commonly used for enhancement of vessels in MR angiography or for brain tumor enhancement associated with the degradation of the blood-brain barrier. Properties of contrast matter: it should not be toxic, it should not be antigenic, it must be dissolved in water, it should be stable against chemical and heat, it should not create permanent change in the body, it should be removed from the body quickly and selectively, and it should have a low viscosity.
Lastly, I would like to talk about CT angiography, which is the last of the three techniques that we mentioned earlier. So with this technique, what happens is that we use a contrast material. The contrast material is injected, and the CT scanning takes place to get a visual and diagnose uh, vascular pathologies such as aneurysms or blockages. And we're not going to be going into much detail about this because it has a lot of common features with the conventional technique. In the recent years, the CT angiography is preferred more and more compared to the conventional technique. This is due to several reasons. One of the main one is that the CT angiography is less invasive compared to the conventional method. However, the conventional method always provides better resolution images, and this is one reason why sometimes doctors prefer that. Another reason is that this is an older technique, Hence, it's still preferred by some of the older doctors because they feel more comfortable with it. And this is it. Thank you for listening. Uh, I hope we were able to provide you with a good info about how angiography works. Yes, thank you.